Okay, good afternoon, folks. Thank you for patiently waiting for us. Looks like technology is finally working for us. So we'll go ahead and get started. My name is Piotrowski. I'll be presenting for today. I am the Executive Director of Clarity PSO. So welcome all of you, and thank you for joining today. Just a couple of housekeeping tidbits before we get into the content for today. We will have folks on mute for the remainder of the presentation. We will have some time towards the end for a question and answer. On the right-hand side of your screen, you should be a little chat box. If you do have questions that come up through the course of the presentation and you want to just submit them, go ahead and do that. We'll save a few minutes at the end for a question and answer. We will be trying to record today's presentation. That will be available at the end of today, so we will keep you posted as to the availability of a recording. So I'd like to start by just saying there's a number of different folks from different points of view on the call today, including other PSOs, healthcare providers, stakeholders from a patient safety perspective. So I'll try to do my best to give you all something new, maybe something you haven't heard before, or some food for thought from each of your different perspectives in patient safety and healthcare delivery. The way that I'll do that is to go through essentially three things in a number of different contexts. We'll talk a little bit about the general framework of the PSO, how it's structured. We'll talk some specifics about how the program can be implemented and applied, 2 or 3 examples of how we and other PSOs have been able to advance care delivery using the patient safety program. And then we'll talk a little bit about where this is going into the future and get you all thinking about, if you're not already participating, maybe why you should be or where you can look for the PSO to be headed in the future. So what does it mean to participate in a PSO? And for these next couple of slides, we'll just kind of go through generally where the program has come from. And essentially, we're going to go back to 1999 and the IOM reports, and the idea that many patients are killed each year as a result of medical errors, and it costs us billions and billions of dollars every year to recover from patients who are harmed as a result of care delivery. And so sometime between those reports and when the Patient Safety Act, the PSQIA statute, was published in 2005, a lot of research came about to figure out, well, what are some of the concerns about error reporting? Why don't we do a better job? Why don't we have a better grasp on errors in healthcare? And lots of people weighed in on the various reasons why that is. Just a couple listed here, and we'll go through these. First is, we live in a very litigious society in healthcare, and right, wrong, or otherwise, we have concerns that when we bring up errors or unexpected issues in the process of care delivery, those things could be used against us in a litigious or punitive way. It's a very, very legitimate stress and concern that healthcare providers have. Some of the other issues that we've identified is that when you look at protections, the discoverability, the confidentiality of information, and what the states provide, mostly to hospitals, by the way, that varies quite a bit from state to state. Towards the end of the presentation today, we'll talk a little bit about case laws in a couple of different states and how even the interpretations at the state level are very different in terms of what should and could be protected and what is actually discoverable in courts and subpoenas for information. Prior to 2005, again, when the Patient Safety Act was passed into law, there really was no federal protection, an umbrella of safety for providers to, in a very confidential and privileged, protected way, do the due diligence towards improving quality and safety. While some might argue that the Healthcare Quality Improvement Act is out there, just remember that's a statute really designed for the immunity of physicians making comments about peers and peer review, so it's somewhat limited to just those comments. What we're talking about with the Patient Safety Act is a much broader, much farther reaching type of statute that is both a privilege and a confidentiality protection. We won't get too much into the specifics about defining those two things. There are other webinars that can do that, so this is a little bit higher level so we can get into more of the application process of the Patient Safety Act. And then finally, one other point, when we looked at, how we determine data, how we look at data, how we analyze data, we do it and have historically done this in a very siloed manner. It's often insufficient. It's often not done in the standard way. So one of the examples we'll talk about a little bit later in the presentation is common formats, which are a set of standard templates that AHRQ has created to be developed for the PSO program. But historically, we don't share information, as much information as we could, about what we learn from errors. It's often a siloed type of data analysis. So all that sort of development, all that history goes into how the development of the statute was written. So it was passed into law in 2005. This is the statute that allows for us PSOs to exist. And it wasn't until sometime later in 2009 where we received what we call our marching orders. And so these are the things that we are required to do as patient safety organizations. It also flushes out what providers, healthcare providers, are required to do in terms of their compliance with participating in the program. So the motives for why providers are going to want to participate is different. In some states, like Florida, for example, there aren't a lot of protections at the state level. And so from a protections perspective, one of the reasons why the federal statute is so broad is because we want to be able to encompass as many providers as we can. So first and foremost, the protections that are offered through the Patient Safety Act are very broad, and it includes lots of people. And so that's going to be one motivation, is to get protections so that you can develop the Learning Lab. And the Learning Lab is we often refer to as the place where you identify the opportunities to learn. And without having some protections over that Learning Lab, it could be somewhat limited. And so we could be a little bit apprehensive about the depth at which we look into learning from errors. And so with the Patient Safety Act statute, it opens up and encourages us to really look a little more deeply, again, in this protected Learning Lab at where we have opportunities to improve. And then finally, fostering a culture of safety. This is another big reason why providers are interested. So it's going beyond the punitive measures. It's going beyond the litigious stuff. It's really looking at how do we foster a culture of safety. And in fact, when you read the final rule regulations for PSOs, it actually uses that phrase. One of its truest intents is to foster a culture of safety, to provide a protected area where providers could be encouraged to report more, deeper, better, so on and so forth. That's really one of the truest intents of the Patient Safety Act. It's got to start with a couple of things. And the PSOs out there who have been doing this for a long time and really understand what needs to happen, it starts with a really strong structure. This is an example, a very skeleton example of a patient safety evaluation system, which is a requirement. It's the place where all of your protections begin. So this is a requirement of both healthcare providers and PSOs. So we all do this, right? The way in which a healthcare provider would set up their patient safety evaluation system is going to differ. AHRQ, our governing body for the PSO, really isn't that prescriptive on what a PSCS should look like. So you have a lot of flexibility in how you're going to manage your PSO. A couple of things to point out. Number one, get full system support. And so one of the things that we'll do is when we create a PSCS and we have a good documented structure, policy workflows, and all the tools that go along with describing a patient safety evaluation system, we'll make sure the CEO knows about it. We'll make sure that the board of directors know about it so they can really support what we're trying to do here in advancing quality and safety. That's a critical aspect. So from the bottom from the bottom up, from the top down, it's really fully supporting this from a systems perspective. Develop a relationship with your PSO. So Clarity PSO, we have actually done consultation for other PSOs, some who are new into the business and some who have been around for a while and want to look at things differently, maybe do some critique of structure aspects. What we often find is there's not a really good, solid relationship between a provider and a PSO. And that's a little discouraging because the better you know your providers, the better you'll be able to service them. The more you'll understand about patient safety, the more they will interact with you and with the other providers in the PSO to drive those opportunities to improve care. So there really needs to be a strong relationship between the PSO and the healthcare providers participating. And there's lots of different ways to do that. The other thing, and as we described here in the visual, is to ensure your protections by constructing a good patient safety evaluation system. This means defining how you're going to manage data, how you're actually physically going to get it reported to the PSO, what the PSO is going to do with that information with you and for you, how it's going to come back to you. Those are all important aspects. And one of the tools, and again, we'll talk about this towards the end of the webinar, one of the tools and pieces of information we use in constructing PSESs is to look at what's happening with case law. How are things being interpreted in the courts? Where have providers maybe struggled with being clear on what their patient safety evaluation system is? How they comply with the other mandatory requirements. If they are in a state, for example, where mandatory reporting is a requirement, you still have to do that. But can you do it in such a way where you meet your obligations of mandatory reporting, but all the other information, all the other analysis is clearly identified as being part of your patient safety evaluation system? We can't stress enough how important it is to have a strong patient safety evaluation system. And know your systems and communicate. So if you are in a larger organization, for example, we see this with some large healthcare providers, they're not even aware of where all of the information is in their system that could potentially be quality and safety related. So it's critical to know your systems and communicate internally about where all those pieces of sensitive quality safety information are. Engage with other providers. This goes along with the relationship with the PSO. One of the greatest benefits that we have heard from other healthcare providers is the opportunity to talk to other providers. So we start to break down those silos, which we talked about at the beginning of the presentation. And you may not necessarily have to reinvent the wheel. If it's in the interest of quality and safety, it's okay to beg, borrow, and steal from other providers if it means that at the end of the day our patients are going to be safer and better cared for. So talk with other providers. That's a critical part of learning from each other and creating a learning laboratory. If you do those things, then you're going to be actively participating in patient safety activities. Through the examples we go through in a couple of slides, we'll talk about some specific activities that we've been able to do. We'll talk about how there's a great variation in what providers do in terms of their patient safety activity work. So that's a critical step. And at the end of all of this, assuming you've set up your structures correctly, assuming you have all the right relationships and communication and you're fostering a culture of safety, it's really about how are we going to improve care? What are the things we're going to do and what are they going to implement to make care safer? So in the ideal world, it's a couple of things. We often talk about fostering a culture of safety, so let me just break out a little bit more about what we're talking about here, and I'm going to steal some comments that I've heard from Sidney Dekker. Sidney Dekker is one of the international thought leaders in terms of safety engineering. He's very well known, has lots of books. He's currently down in Australia at a university teaching, but he's very well known in terms of this safety engineering. So the first thing really is looking at making sure you understand that an entire organization creates a culture, meaning it has got to be from the top down and the bottom up. Everybody is involved in creating the culture. So from a culture of safety perspective, what we're talking about is quite simply a safe culture means that the boss is allowed to hear bad news. I'll say that again. A culture of safety means that the boss, the leaders in the organization, it's okay, and they are okay with hearing bad news, the things that don't go well, the things that go from unexpected or just go awry with the care delivery processes. That's what we're talking about with a culture of safety. Those things are okay to bring up and report. Learning culture, no finger pointing. So we're going to transition from the traditional patient was harmed, what happened, who did it, to patient was harmed, what happened, how do we prevent this from happening again? Let's remove the systems that are broken. Let's fix the systems we have to make sure that they are supporting healthcare providers and organizations in the appropriate way. Fostering a culture of learning. And then the third aspect is a culture of justice. If we identify things that need to be fixed, then let's hold ourselves accountable for fixing them and making sure that the right things are happening, the right people are in the right place to make sure that care is going that we want, and hold ourselves accountable to make sure those things are being done. So in the ideal world, this is where we're getting to. And if you can say in the organizations that you're in or the healthcare providers that you work with that they are doing these things, then this is where we need to be. This is where the PSO, this is the core of where the PSO needs to be. Let's switch gears a little bit. Let's talk a little bit about some specific examples that we have been able to do. And the first example I'm going to use is common format reporting. And now, lots of different PSOs do patient safety activities in different ways. Some PSOs have registries where they're looking at outcome data. Some PSOs have anonymous reporting data. Some PSOs do safe table, round table discussions, which really aren't even a specific event necessarily, but just discussions about patient safety. All those things are okay, and they're all patient safety activities. I want to be really specific about common format reporting in particular because, as I mentioned earlier, AHRQ has created the common formats for the PSO so that across the country we could compare apples to apples with standard templates and have the right definitions. Now, this has not been easy. Most of the common format reporting today is hospital-based, although that's changing to long-term care and ambulatory and other specialty types of providers. But I want to talk a little bit about common formats and how we've been able to see this advance over the last couple of years. They are becoming more widely accepted by a number of stakeholders and other federal agencies and some PSOs, including Clarity. We've been doing common format reporting for quite a few years now. So let me describe a specific example of how we've been able to use common formats to make a difference in care delivery. It starts with having good data collection methods. And this is a screenshot of the tool that Clarity PSO uses, and you see the little blue arrows on the side here are areas where common format data elements are built right into a healthcare provider's safety, event reporting, incident reporting, event management system. And so it's got to start with making sure that those things are built in. Now, common formats were designed originally so that frontline staff could actually report events. That's not always easy because some of the information is very specific, and when a provider is reporting an event, he or she may not have or know all the information that is required. So it varies a little bit in terms of a frontline provider and a department head or a risk manager or some other person in the organization doing follow-up on a particular event. But you got to have good data collection methods, and you got to have the right tools to be able to collect information the way you want it to, which would include, in this case, mapping to things like the common format. So that's critical. You got to have a good system. When you have a good system and it's mapped and you have good definitions and people know how to use the system, they know how to report specific events, you can start to analyze information. This is a very simple slide set that looks at medication errors, particularly for incorrect patients over the course of time, over the course of quarters in the last year and a half or so. So you can say, okay, this provider's, they're monitoring incorrect patients, and it looks like, from a trend perspective, they're doing pretty good. Don't fall into the silo trap. And so what do we mean by that? Well, let's ask some questions. How do I know this is good? You can say the organization by themselves looks like they may be improving. Okay, maybe. There looks like they're averaging around 11 or 12%. Is that good? Is that bad? Well, how do I measure relative improvement? Okay, so only by myself I might say, again, that I'm improving, but what do I compare this to? What if I had benchmarks to compare this to? And this is where the PSO is really, really critical. So we take this provider and we line them up with other providers and we say, all right, well, let's look at how you perform compared to other providers. And if we say that provider we saw on the previous slide, here you are, incorrect patients, and all of a sudden, it looks like there could be an outlier. We do some statistical math stuff behind the scenes and we say, yeah, this is actually an outlier as compared to where their other events are falling. So then we say patient identification, at least in the process of medication administration, is often correlated with harmful events or serious events or big deals, right? So now let's look at that. So the first thing we've done is we've made our provider aware of this reporting. We've made them aware that if you look at just yourself, you may have appeared to be improving over time, but all in all, if we compare you to other providers, your percentage of incorrect patient identification in the medication administration process is about double what 13 or 14 or 15 or 100 other hospitals are doing. So let's dig into that and find out. So we talked to the providers and we realized that there really isn't a standard way to do double checks for certain medications, and patients aren't, the policies for patient identification are a little bit inconsistent, and there's multiple versions of a patient identification policy. So we fixed those things, right? So we implement system-wide education. We implement some new things, Q3, so somewhere's right around here, and then we monitor them over time. And we say, okay, we've made some new implementations about medication administration, in particular for patient identification, and then we monitor those harmful events over time, and you see them start to improve. What a great success story. And so this is just one example of many that we've been able to use common formats in particular to actually drive improvements, and this is in particular for patient identification and harmful events in the medication administration process. So these are the kinds of things that the PSOs can do and should be doing. Let me give you another example. This is a little bit more high level. And when we look at the segments of healthcare where PSOs are operating, they're going to change. So the common format example we gave was hospital-based. Let's go outside the hospital. Let's look at ambulatory settings. So this is a project that we've been doing over the last couple of years that looks at a triad of information. And the triad is here, the red, green, and blue or black there. The triad information does a couple of things. The first thing it does is to say, where have we gotten lawsuits from a claims perspective? Oftentimes in ambulatory settings, it's very difficult for those healthcare providers to really understand risk management from a claims perspective, risk management processes. They don't have a lot of resources sometimes to do those sorts of things. But we could collect some data and say, where are the kinds of things you've gotten lawsuits from? Where have you gotten claims from? Where has it costed you money in terms of legal fees and so forth, in terms of care delivery process issues? So we start to identify those areas. Then we do a survey with them and we ask the providers in that setting, how well do you do at certain areas of quality and safety? And we ask them a whole bunch of questions, including tracking patients, compliance, all different sorts of questions. Then we start to say, all right, of all those assessments and the things that you've said that maybe you haven't done really well, do they correlate with the areas where you've gotten sued or gotten in trouble? And we start to then pinpoint the areas where they've said, we don't do a good job at this, and oh, by the way, it's affected, it's hit our bottom line by way of lawsuits or claims or legal fees. Then what we've done in the midst of doing this analysis, we've created an error reporting system to say, okay, if we give people a real-time event reporting tool that is specific for ambulatory safety, and we monitor those events over time, what are we collecting? And when we look beyond the traditional high-level event types and we look at the contributing factors, we can identify the things that, number one, we are associated with the things that we've said we don't do very well from an operations, quality, safety perspective, and is also correlated with lawsuits. So when you tie these things together, you can get really specific on areas where you need to focus. And maybe it's simply the process for when a provider makes a referral, who is tracking that, what is the communication with the referring physician, how do we monitor those things, do we have the right documentation, tools, metrics to make those things visible to us so we know what our performance is over time. You can get pretty darn specific on the areas where you need to improve. Really, really great program, and we'd encourage folks to really look at ambulatory safety. Now, there's our 3 areas. One other example, again, a little bit higher level here, and we'll switch gears again to talk about where we're going in the future. This is a focused segment of healthcare that is specific for radiation oncology. So in this program, what we've done is first start here with the AHRQ common format. We said, okay, so first of all, the radiation oncology group says we want to advance quality and safety. So how do we start to collect information? Well, let's start with common formats. What from the common formats is applicable to radiation oncology? So we start with the more general forms in terms of severity scales, contributing factors, those sorts of things. And then we say, okay, well, there's a community of radiation oncology providers who've already done a lot of work in terms of how to report errors, incidents, unsafe conditions, near misses, and what are all the specific data elements that need to go into building that sort of system. So what we've effectively done is create radiation oncology common formats, if you will, for this specialty. Then we build them into the right tool, and then it's appropriate for PSO reporting. So, hospital areas, ambulatory areas, this is a combination of both, and it's a specialty type of focus. There are lots of PSOs who are specialty focused, but this is the kind of work that PSOs need to be doing. As I mentioned at the onset, patient safety activities can vary. Here's a list of some things that we've been able to do. Other PSOs have done some of these things. Other PSOs have done very different things. What I'd like to stress to you is if you are working, depending on your vantage point, if you're a PSO or a healthcare provider or someone of general interest for the PSO program, think about what can be possible. Think about the kinds of safety activities that can happen, and that's what we want to stress to you here. It can be a lot of things. Going way back to the definitions in the Patient Safety Act regulations, the information that's eligible for protection, and if you read the definition, the first 2 words of that definition are any data, and then it goes on for 2 paragraphs to describe what the protected information is. But it can be a lot of different things, and it certainly will be a lot of different things depending on the segment of healthcare where you are working. So think about that. Think about all the different types of things that can be possible with patient safety work. All right, where are we headed? So where are we going? So we'll start very high level, general, and then we'll talk specifically about the Affordable Care Act and then perhaps some legal cases if we have time towards the end. This is a slide set of where PSOs are located. We often get questions about how many PSOs are out there. This is available from AHRQ's PSO website. At any given time, there's about 80 listed PSOs. Approximately 50 or so PSOs have delisted. In other words, they've gotten out of the marketplace for one reason or another. So the number's been around 80. The types of PSOs vary from very general, like a Clarity PSO, for example. We basically touch every area of healthcare. There are some very specific, like anesthesia, a blood bank, radiation oncology. There's very different types of PSOs for very different types of reasons. So, again, depending on your point of view for today's webinar, if you are considering PSO participation, think about what's going to be the best fit for you. Is it going to be a more global type of approach or very specific? The final rule regulations also say that providers can participate in multiple PSOs, and one of the primary reasons why you'd want to do that is because you want the general patient safety view, but you also want a specific type of view. So, for example, the one example that we gave earlier about radiation oncology, we have providers who are specifically reporting for that radiation oncology program, which is obviously very specialty specific, but then there's also the Clarity PSO general type of PSO. So depending on why you're going to want to participate, we should be, the type of PSO that you're working with. If you look at the types of providers who are participating, very generally, this is information taken from AHRQ's profile data. So PSOs will submit general information to AHRQ on an annual basis. And this is from last year. We'll get another update in just a few months here, or maybe end of first or second quarter next year for 2014 data. But if you look at the types of providers here, here's our general hospitals. So of the over 8,000 or so hospitals in the country, you can see how many are reporting. Interestingly, there's no specific breakdown here for that ambulatory care. In other words, the care that's rendered outside of the traditional hospital. So if you look at some of the definitions here, nearly all of these could have some aspect of ambulatory care. Certainly the other category would, with ambulances and ambulatory surgery centers. But some of these other areas also have components of ambulatory care. So again, just a high-level idea of the kinds of providers who are actually participating in the PSO, at least as of last year. Okay, we'll switch gears again on you. The network of patient safety databases. So one of the ultimate goals of the PSO program is to create a national database, a national error reporting database. And the third party, the Privacy Protection Center, is the folks who are working with AHRQ to create this. And this has been quite the work in progress for the last several years. There's a very specific type of technical specification that goes into reporting, and it does require some diligence on the PSO's part to make sure we're doing this correctly. So today, at least fairly recently, these numbers change obviously quite a bit. There are only 4 PSOs who are actually reporting live data to the database. There are a number of PSOs, including Clarity for that matter, that are actually doing test data, which means, hey, we've got good data, and you saw a small example of that with the medication example earlier, that we have good data that we want to get up to the database. There's a good handful of data that the PSO Privacy Protection Center is looking at, and it's our goal that over the next several months we actually make the network of patient safety database a live database that we can use to look at trends, errors across the country. And so it's those common formats, and there are very event-specific common formats and some general common formats which look at harm scales and general contributing factors, those sorts of things. We can look at that data and make inferences of what's happening across the country. And so PSOs, AHRQ, who, as I said, is the governing body for the PSO program, and even healthcare providers could use this database to have a way to compare, to have a way to analyze, to have a way to look at specific types of errors, unsafe conditions, near misses that are occurring and being reported. So more to come on the network of patient safety databases. Again, if you go to AHRQ's website, you'll get an idea of the PSO Privacy Protection Center and the network of patient safety databases and what it is and hopefully where we're going. Okay, future of common format reporting. So the database is one thing. PSOs currently working to use common formats. That's happening, and those things are all great. But what about into the future? What about years from now? And common formats today, one might argue, are somewhat limited. There are other aspects of care delivery, other sources of data that are not incorporated today into common formats. So where are these going to go? Well, the first is going to be interfacing and being interoperable, the concept of interoperability with things like EMRs or other types of databases. How are we going to be able to tie those information pieces together? And we're not talking about mixing data. We're not talking about putting incident reports in EMRs. We're just talking about the analysis of data. How do we tie these things together at either the provider level, more importantly at the PSO level? We need to be able to do that. Plans for surveillance. Once we can look at interfacing with EMRs, once we can look at trying to tie quality outcomes, patient outcomes to event reports, we really need to tie those things together. So if on the one hand, a safety event or an incident report is only a small fraction of the story, or a small fraction of the data that can be possible. We have to look at a larger picture of data. And if we can use incident reports, if we can use safety events, if we can use data collected in EMR and surveillance those things, in other words, just monitor them over time, look at what's happening in those systems, we might be able to get to really good predictive models and be able to say, you know, these are the patients that are most at risk. And these are, more importantly, the very specific times of a patient's care delivery process where they're going to be most at risk. Let's tackle those areas from a safety quality perspective and improve care very proactively from a predictive model standpoint. We need to be able to do that. Denominator rate comparisons. Today, common formats are mostly frequency-based. So it's the number of events over time compared to a larger data bank of events reported. But what about all the patients in the system? So, for example, a common one is falls. Falls are an easy denominator rate comparison to do because most hospitals, at least, would say it's the falls per 1,000 patient days. Long-term care, you can say, you know, falls per 100 or per 1,000 resident days. Ambulatory, you might still be able to do the same thing. You just have to determine, are you going to have your metric based on patients or patient encounters, which could be very different. The same is true for medications. You could say, you could have several metrics, rate metrics for medications. You might say the number of errors per prescriptions, the number of errors per medication administration, the number of errors per pharmacy dispensing. So it could vary. So we need to get there. AHRQ is talking a lot about this and how we could start to incorporate denominator data and get rate comparisons using common format information. And then lastly, system replacement. So one good example is QSAR's Quality Safety Reporting System. So if we use the common formats in the right way, if we're advancing common formats in the right way and we're able to do all of these things and there's lots of providers using them, we will be able to replace current systems. Today, we struggle with things like physician data banks and registries and NDNQI, there's all kinds of, you know, and others, there's other quality safety databases out there, and one might argue they're out there for different reasons, but from an error reporting, from a safety perspective, they are somewhat disparate, including the common formats. So can we look at putting a lot more of these things together to have a more national look at error reporting and quality safety reporting? Okay. So we'll switch gears one more time here, and then I think we'll wrap up, and then we can save a couple of minutes for questions. Voluntary versus required participation. So today, mostly, the PSO is a voluntary program, meaning there aren't any requirements. I'm not going to spend too much time on this slide. For many of you, this is probably repeat, even if you are participating in a PSO or not. Nonetheless, the Affordable Care Act references two instances where PSO work should be considered. One is not a requirement, but actually a recommendation. The other is a requirement. The recommendation piece comes in from the readmissions perspective. So those hospitals who are struggling with 30-day readmissions, it's recommended to do work with a PSO. The other is a requirement, well, and that is in relation to the health insurance exchange. So the hospitals who are going to be participating in the health insurance exchange will be required to conduct their work through a patient safety evaluation system. So we have found out through CMS that this does mean PSO participation. The issue is this was supposed to go into effect January 1 of 2015, and now because of some metrics and some understanding of really of where the PSO is going and what it means to participate in the PSO, this will be a phased-in approach over the next few years. So I would anticipate that probably in 2015 sometime we see some at least proposed ruling or regulations on what it means for this insurance exchange PSO requirement. Okay, last slide, and then we'll save some time for questions. So one of the key elements for providers in terms of how you're going to set up a patient safety evaluation system, in terms of understanding how the statute is interpreted at your state level or across the country for that matter, It's happening now, and these are just a few, not all, but a few of the case laws that are currently being adjudicated in courts. So recall earlier on in the presentation we mentioned that the protections afforded to healthcare providers under the statute are two things. It's a privilege and it's a confidentiality. So the privilege part are the things that are adjudicated in courts, and by privilege we mean things aren't subject to FOIA, they're not subject to court orders or subpoenas, those sorts of things. So they're decisions that are made when a healthcare provider is compelled to disclose. These are the decisions that are made in the courts. So a couple of decisions. This has been challenging. There's really not a ton of case law, but some good cases and some bad cases. One good case is the one in Illinois with Walgreens, the fourth one down the list here, and that is actually a decision that went to the appellate courts in Illinois. Here in Illinois, Clarity's in Chicago, so we watched the evolution of this case, and it was determined that Walgreens met their burden of proof and that their information was in fact protected. We've got hospital cases where the courts have said information is protected, like the IASIS case, but there's other more recent cases like the Baptist case and then the couple of cases in Kentucky where courts have said basic information like incident reports or adverse events are not protected information. So there's some conflict, and the conflict depends, number one, on the state, number two, the person interpreting the statutory nature of the privilege assertion. So what we don't have today, though, is a federal court case. So I think what we're seeing is that at some point, we're going to have to get this up one level because there is some conflict at the state level. We're going to have to get this up to the federal courts. And so today, at least to our knowledge, there's not been a federal case where courts have adjudicated or made it an opinion about an interpretation of the Patient Safety Act statute. So we're left with what we have today. So again, the PSOs who are on the call today and the providers working with PSOs out there, it's important to at least understand what are the things that our folks are talking about in these court cases, and what are the specific elements that you can do as a healthcare provider, or what healthcare providers can do to build into their patient safety evaluation system to have as bulletproof possible the protections so that you could keep that safe umbrella, so that you are truly encouraged to dig up and uncover all the opportunities to improve quality of care. So I'll highlight a couple of things of what we're hearing. Number one is be very specific about having a relationship with your PSO. Can you identify a written contract? Be very specific about a patient safety evaluation system. Have you documented your patient safety evaluation system? Do you revise your policy? Keep your revision dates of your PSES policy. Do you have specific instances of your policy, certain systems or certain aspects of your system that are protected, and where you specifically carve out information that's not protected? So, for example, if there are hospitals on the call today who have mandatory state reporting, be specific that that's not a part of your patient safety evaluation system. If in fact the incident reports you're collecting in your system, you are going to report to your state, be specific about what's in your evaluation system and what's out of your evaluation system. Be careful about having a dispersed type of patient safety evaluation system. In other words, if there are multiple areas in your organization where patient safety work product, the information that's protected, if there are multiple areas in the hospital where this information exists, be careful about controlling that information, making sure it's internal, making sure there aren't multiple copies of information all over the organization. Have some controls and educate folks and make sure folks understand what is the PSES, what it looks like, and where it is in the health system, the hospital or the organization, and what's protected and what's not. So all of those things need to be as clean and as clearly spelled out as possible. Your PSO should be helping you do that by way of policies, trying to understand what your quality and safety process is, what's appropriate for a PSES and what's not. So disciplinary actions, for example, are going to not be an appropriate use of patient safety evaluation system work. And by disciplinary actions, we mean those things that are going to be adverse employee actions, so terminating an employee, revoking a physician's privileges, for example. Have a separate process for those things. The understanding is that, if you say something's patient safety work product in your organization, you can use it for any purpose you want. So, you can, I suppose, this is risky, you can use patient safety work product for disciplinary actions, but there are risks. And the risks are, if an employee sues an organization for wrongful termination, then you can't use the work product in court. You run the risk of blowing your disclosures for all of your information. So, again, the main point is there are appropriate uses of the patient safety evaluation system, and your PSO should help you to determine what should be in and what should be out, as well as your understanding as a healthcare provider of what's appropriate quality safety, work quality safety analysis. Okay, so I just saved a couple of minutes so we can run through some questions. I'll just say thanks. My contact information is on a slide here. Some things we went through very high level today. Some specific examples. Did we get a recording? We do have a recording for the webinar, so we will be able to supply that to you once that's available. I'll just go through some questions here really quickly from the chat box, so just bear with us 1 minute here. Okay, so the first question is, are near misses reported? And the answer is absolutely. So let me get on my soapbox about near misses for a minute. First off, the near misses are a part of common format reporting. At the most fundamental level, there are 3 types of incidents that the common formats recognize. Number 1 is a patient event. In other words, something has actually reached a patient. An event has occurred to a patient. The other is a near miss, meaning that an event was reported before it had the opportunity to reach a patient, right? The traditional definition of near miss or near hit. And then the third is unsafe conditions, which means that something's reported that doesn't have to be directly related to the care delivery process, but it's unsafe. So, for example, an unsafe condition would be pharmacist walks into a medication room and says, boy, we've got these bins here for medications, but there's really no clear documentation. There's some look-alike, sound-alike medications. This is problem prone. If we don't fix this, we're probably going to have an issue. An unsafe condition. Let's just fix it before it has an opportunity to develop into something more. A patient safety event is fairly straightforward. Those are the things that actually reach the patient. Near misses are reported. They are reported to us. We have a good amount of near misses. In fact, a year or two ago, we did an analysis of 30,000 near miss events from a number of health systems who have been collecting near miss incidents. It ranges from all over the board. My opinion, and I can't prove this, this is anecdotal, but my opinion is that if we are reporting the right kinds of information, if we have a culture of safety and a culture of learning and a culture of justice and awareness of what needs to be reported, we should be reporting near misses 8 to 10 times as often as we are reporting incidents, 8 to 10 times more. And I can't prove that in healthcare, but we definitely need to do a better job at near miss reporting. In most instances that I have seen with our clients, with almost all of the other PSOs that I've discussed with, there are more incidents than near misses. It's just the opposite. So yes, we do report them, and we absolutely encourage providers to report everything and anything. The key is to have good data collection methods so that it's fast. Use a mobile device. Have a near miss where you can report in just a couple of seconds. Right? It's got to be fast and convenient. And I think if we do that, then maybe we'll be better at just getting the awareness out there that let's report everything. Let's report everything that we possibly can. Okay. So the next question that comes in, can you comment on what analysis methods are used to analyze the incident reports? I knew that question was going to come up. There's various methods. Number 1 is that we have employed a team of clinical analysts, which includes 3 nurses, 1 mathematics data analysis, and a group of national advisory council members. Many PSOs have advisory council members. Some have 20 or 30. I don't know how you can handle and manage and control that. But we have a group of advisory council members who are very active with us. and they provide subject matter expertise. They'll actually go through a case study. They'll actually talk with a healthcare provider and go through a case study, go through an RCA. So for example, we've got an OB expert, we've got infectious disease, ED, surgery, nursing operations. Depending on the type of issue, they'll get really specific. So one kind of analysis is to critique a provider's RCA or assist a provider in going through an RCA or a peer review and really getting into the deep roots of what's happening with a particular case. So that's one method. The other analysis we use is to use the common format aggregate report templates. So there's a common format template, which is just the event type, but there's also an aggregate template which describes when you're going to take events and aggregate them, how you might do that. So we've actually used a template that was provided by AHRQ. Then what we employ there are statistical significance methods. We look at frequencies. We look at rate comparisons. There's a couple folks here at Clarity who are use Six Sigma, the control charts and run charts and all those good types of methods to look at trend analysis. Analysis is a very broad term. You can do analysis in essentially any way. There's a number of different ways to measure validity and reliability as well. So we'll employ traditional statistics. We'll look at case study analysis review. We'll use aggregate templates. So we use a variety of different methods to do analysis. Next slide is, will you make these slides available? The answer is yes, as well as a recording. So yes, we can make that available to participants at the end of the call. Okay, the next question is a little bit tricky, and I'll tell you why. So this question is, do you collaborate with researchers to investigate state-of-the-art analytic methods to process incident reports and identify risks? It's a possibility. It's an option. AHRQ is actually doing studies on how this information is being analyzed, how this information is being interpreted, and they've got analytics folks helping them and research folks helping them. Clarity PSO has not done a research project on analytic methods. We would certainly be open to that. I think most PSOs should be open to that. But it's also important to think about what AHRQ is doing and can we tie all those things together. So if we're going to really be looking at incident reporting with common formats and with a PSO, let's put everybody on the same page so we're all benefiting from what really is state-of-the-art incident report analysis. So that's a very good question. Okay, the next question is, for incident reports, can managers outside of the quality department help complete the data collection? Let me tell you what I think that question means, and if I'm off base, please email me offline and we can talk some more about this. When you're setting up an evaluation system, there really aren't any limits on the internal organization having access to or participating in quality safety activities. So we often will have quality safety, if it's applicable or appropriate, risk management, nursing peer review, physician peer review committees, medication safety subcommittees. We'll have other folks help to complete information if that's appropriate. Pharmacies sometimes will help complete information. So yes, multiple people can help to make the data more accurate as well as analyze the data at the end. And so it just depends on the organization, but certainly you can do that. And folks do have a number of folks help to review an incident, make sure the incident is reported accurately and as complete as possible, and then do the analysis on the back end. Okay, so last question. How do you charge for these services? Well, I'll answer as specifically as we can. In the nature of business competition, maybe we can have some of that discussion offline. But generally, for a hospital, what we see is that PSOs will charge per licensed bed. There are other methods for charging for that. It's going to depend on here's what we see typically. It's going to depend on the size of the organization. It's going to depend on what the organization wants to do. So are we looking at all aspects of safety or a very specific specialty type of focus? It's going to depend on how many activities you want to do with the PSO per year. So some providers who work with us, for example, they'll want 8 safety events done every year, 2 per quarter. Okay, pretty straightforward. We can do that. Your price is going to reflect the amount of time it takes to do those activities and what goes into them and so on and so forth. So to answer your question as specific as we can, number one is going to be it's going to depend on size, and it's going to depend on the types of activities that you want to conduct through your safety evaluation system and your patient safety organization contract. Okay, so the next question is, do the events, incidents, near misses, reports have free text, or do they follow common formats? Both. They do both. And common formats are designed, and I think I mentioned this earlier, common formats are designed to be reported by the frontline staff. So they'll be very specific, answer options, drop-downs, radio button types of questions that are very fast, very straightforward. But they're not intended to be the end-all, be-all for a particular type of event. So, for example, one of the common format events is medications. Medications have, maybe the common format for medications has about 20 questions. That's not going to be all of the kinds of questions that maybe you want to ask in your safety committees, more on your follow-up investigations. Maybe you want more information or you want different information, so add that in there. The common format is intended to be the minimum type of data set, so we're going to add more information onto a particular type of event. Most organizations do. One of the ways to tell the story of what's really happened is through free text. It takes more time to do the analysis, but it's important, and there's a lot of rich information in the free text fields when people are reporting. So yes, there are areas for that, and that's going to depend on the organization, how much standard common format questions you want to have, and how much availability do you want to have the providers in terms of providing free text answers. Everybody does both for the most part. Just depends how much of that depends on the organization. All right, so I think the last question here is, do you provide data upload as well as manual entry? Do the majority of your members enter information manually? You mean report to the PSO, I think. So let me tell you what I think you're asking, and then if I'm not, again, take this offline and we can speak specifically. So the information going from the provider to the PSO, does that process occur manually, or are there some sort of automated processes for getting information from the provider to the PSO? The answer is both, and it depends on the organization. So as said earlier, you got to have good data collection methodologies. And one of those data collection methodologies is to be able to collect safety events in an electronic format. The tool that we use for a lot of our hospitals, we designed. So the Healthcare Safety Zone portal, we've actually designed that, and Clarity Group, who's the parent company for Clarity PSO, owns that product. So a lot of the hospitals will use that. And so it's very easy for us to write a query to Clarity Group with agreement from the hospital to say, transfer this data over, and then we have automated mapping on the back end to just have that information sent over to Clarity PSO. So there's some interfacing options also where you could write a file to say, have your system mapped to these data files. So we've tinkered with those ideas, but their providers will do both. They will do it manually and they will do it directly. The other option is functional reporting. And functional reporting is where the PSO is allowed access to the provider's systems in one way, shape, or form. And we have providers who will do that. And they'll carve out a part of their system to say, here's the PSO folder. Tom has access to our database. go get the information whenever you want it. This is stuff that's reported to the PSO. So the provider doesn't have to do anything. We just go to their system and we have access to their system. Okay. I think that's all of our questions. We ran a few minutes over. Appreciate those of you who stayed on a little bit longer. If there are additional FOBS questions, please email me directly or call me, and happy to chat some more. We will have the slides available. We will have a recording available. As soon as that's ready, we will distribute that to the group. On behalf of Clarity Group and Clarity PSO, we thank you for your time today and participating in our webinar, and we look forward to seeing you on future webinars. Thank you. Have a great day.